Hereby I open this academic ceremony in which Adriana Solovei will defend the academic thesis discussing alcohol strategies and return on investment of implementing alcohol measurement and brief advice in Latin America. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Prorector and members of the Corona, dear family and friends, colleagues here in the room as well as online, thank you very much for attending the open defense of my dissertation titled Discussing Alcohol. In the next 15 minutes, I would like to explain the content of my PhD research. Alcohol is a public health problem. 1 in 20 deaths is associated with alcohol worldwide, which means that every 10 seconds, a person dies from alcohol-related causes. Alcohol is linked to more than 200 diseases, and it harms not only the consumer, but also those around him, through increased violence, harms on prenatal health, or traffic accidents. Overall, it has been estimated that alcohol costs a country about 2% of its gross domestic product, through costs in healthcare, criminal justice, or productivity loss. Zooming into Latin America, we see that this is a region with the largest alcohol-related harm worldwide after Europe and sub-Saharan Africa. Moreover, alcohol consumption is expected to increase by the year 2030 in the region, so it is important to implement alcohol management programs in the region in order to decrease alcohol consumption. This brings us to the main objective of my PhD research, namely to shed more light on how to best implement such a health program in Latin America called Alcohol Measurement and Brief Advice. But what is alcohol measurement and brief advice? Alcohol measurement means that a patient is asked about his or her alcohol consumption during a healthcare consultation. If the score of this measurement is considered risky drinking, for example, more than 14 glasses of wine per week, then the patient receives brief advice from the healthcare provider, for example, a doctor or a nurse, regarding the importance and ways to reduce drinking, and could also be referred to specialized treatment if needed. Primary healthcare has been shown to be an optimal setting where alcohol measurement and brief advice can be implemented because of the high number of patients visiting it and the credibility of the healthcare providers. However, despite this proven effectiveness, alcohol measurement and brief advice is still not implemented in routine practice in most countries, including countries in Latin America. This brings me to the main aim of my PhD dissertation, or aims, and they were twofold. The first aim was to develop and test a community support package for alcohol measurement and brief advice. And the second aim was to assess the costs and return on investment of alcohol measurement and brief advice. The research was conducted within the international SCALA project, which was implemented in 3 Latin American countries, Colombia, Mexico, and Peru. SCALA was a 4-year study which tested the scale-up of primary healthcare-based prevention and management of heavy drinking and comorbid depression through training and ongoing support embedded in community-based activities. And it was a collaboration of multiple international academic partners. As already mentioned, the first aim of this dissertation was to develop and test a community support package to help healthcare providers to deliver alcohol measurement and brief advice. But what is community support? Community support refers to help and encouragements given by the community that surrounds the healthcare provider, for example, people in the neighborhood or colleagues at the primary healthcare center. In SCALA, we developed a package of community support activities in collaboration with local stakeholders and research partners in the 3 countries. There were 5 main activities. First activity was community advisory boards. In each country, we had a group of 10 to 12 people, mostly from the public healthcare field, who gave advice on optimal implementation of the intervention in their country, and they met regularly during the project. Second, we had project champions. These were 1 or 2 persons in each country who took ownership of the implementation of the project and stimulated healthcare providers to participate in SCALA. Then we had adoption mechanisms. These were a set of activities, particularly at the beginning of the project, that aimed to stimulate healthcare providers to adopt alcohol measurement and brief advice in their practice, for example, by emphasizing the simplicity of the intervention. Support systems. These were a set of activities throughout the project that aimed to stimulate the continuous implementation of the intervention, for example, by providing the healthcare providers with regular feedback about how they were doing during the project. And finally, communication campaigns. These were a set of public communication activities aimed to increase the positive beliefs of both patients and healthcare providers about the importance of discussing alcohol during a healthcare consultation. Here we can see examples of posters that were developed in the 3 countries in their communication campaigns. So all 3 countries found it important to develop such posters and place them in waiting rooms in the primary healthcare centers, but each country chose a different layout for the posters, and they all focused on the importance of discussing alcohol. After developing these community support activities, it was also important to see whether community support is indeed effective at stimulating healthcare providers to offer alcohol measurement and brief advice to their patients. To find out, we compared in each country a municipality that received community support to a municipality that did not receive community support. The data collection lasted 5 months before an abrupt stop at the beginning of the COVID-19 pandemic, and we had 291 healthcare providers participating in the data collection. The results showed that, as we expected, in the municipalities with community support, healthcare providers offered alcohol measurement and brief advice more often to their patients compared to providers in the municipalities without community support. After finding out that community support is indeed effective and helpful, we thought it was interesting to also look at possible mechanisms that can explain this effect. We applied a conceptual model of such explaining mechanisms based on a combination of behavior change models and theories. So the conceptual model suggested that community support will first lead to a higher awareness of support among healthcare providers. Next, this awareness of support was expected to lead to more positive attitudes, or in other words, that healthcare providers would consider alcohol measurement to have many benefits. Awareness of support was also expected to lead to more positive subjective norms, meaning that healthcare providers would experience more positive attitudes also from their colleagues and managers regarding alcohol measurement and brief advice. And also awareness of support was expected to lead to a higher self-efficacy, or in other words, that healthcare providers would be more confident in their ability to offer the intervention to their patients. Then we expected these 3 factors, attitude, subjective norms, and self-efficacy, to lead to a higher intention or willingness among healthcare providers to offer alcohol measurement and brief advice to their patients. And finally, this would then lead to an increase in the number of patients who actually received the intervention. So our statistical analysis revealed the following. Next to the previously mentioned direct effect that we found from community support on the number of patients receiving alcohol measurement and brief advice, we also found that community support indeed led also to a higher awareness of support among healthcare providers, and that this awareness also led to higher self-efficacy in healthcare providers. And we did not find effects on attitudes or subjective norms, but it is possible that if community support would have been implemented longer than 5 months, as we initially planned in Scala, so if we wouldn't have stopped it because of the COVID-19 pandemic, then effects on attitudes and subjective norms would maybe also have been found. So more research is needed on this topic. And we also found that healthcare providers with more positive attitudes about alcohol measurement and brief advice also had higher intentions to implement this intervention. Moving to the second aim of this dissertation, this was to assess the costs and the benefits of implementing an alcohol measurement and brief advice intervention in the 3 Latin American countries. This is important information for policymakers, but what we saw in previous research is that there is very little and scarce literature on this topic, and those studies that have been done were mostly done in Western high-income countries. There were many differences that were found in the previous results. So yeah, we thought it's important to do it in the 3 Scala countries, and in our research we collected and compared the costs in Colombia, Mexico, and Peru, and they were divided into consultation costs and program costs. The consultation costs consisted of, for example, staff payments or salaries, but also costs for the materials used in the consultation. So for example, the sheets that were used to measure alcohol, the tally sheets. And then we had also the program costs. These were consisted of, for example, setup and implementation costs, training of healthcare providers, clinical package costs, so for example, the leaflets that were offered to the patients, and community support costs. The results showed that the cost of one alcohol measurement session were comparable in the 3 countries and were approximately $1.2 international in Colombia, $0.7 international in Mexico, and $1.1 international in Peru. And international dollars is a currency that is often used in research to allow comparability between the countries. Other costs, for example, one community advisory board meeting costed approximately $720 international in Colombia, $830 international in Mexico, and $610 international in Peru. For a training session for healthcare providers, we saw the costs were $480 international in Colombia, $540 in Mexico, and $580 international in Peru. And finally, we also so what would be the cost of offering this intervention to 10,000 patients? And these were $25,000 international in Colombia, $27 international in Mexico, and $34 international in Peru. So these were some modeling analysis that we did for estimating these costs. And then moving forward to the next and the final research question in our research, we wanted to know what are the economic returns of scaling up alcohol measurement and brief advice in primary healthcare, or in other words, is it worth the costs? So for this, we used a return on investment analysis approach. So this means that we assessed both the costs and the gains in terms of monetary outcomes. And this is rarely done in healthcare research because it is difficult to translate health outcomes into financial outcomes. But such an analysis is very valuable for policymakers who are in charge of resource allocation in the public sector. In our analysis, we focused on Mexico, which was the largest of the 3 Scala countries, and the data was collected from the Scala project, the Mexican Ministry of Health, and from previous literature. The results showed that in case that every year 30% of the population in Mexico would receive alcohol measurement for 10 years long, then this would lead to a positive return on investment of 110%, meaning that for every $100 international that are invested in the program, $210 international would be saved in terms of healthcare costs. And we actually also wanted to see what the intervention would do in terms of mortality, reduced mortality in the country. And we found that over 10 years, alcohol measurement and brief advice in Mexico would lead to over 16,000 avoided alcohol-related deaths. So summing up the general conclusions of my PhD research, these are the following. Community support leads to an improved implementation of alcohol measurement and brief advice. Budgeting efforts of health interventions should take local characteristics into account. And scaling up alcohol measurement and brief advice can lead to financial benefits and saved lives. Thank you for your attention, and now I would like to give the word back to the prorector.
Thank you for your presentation. We will now move to discussing your research, and the opposition will be opened by Professor Crutzen, Professor of Behavioral Change and Technology, Maastricht University. Professor Crutzen.
Thank you very much. Dear candidates, my compliments on all your work. On behalf of the chair, I can say that everybody was positive, so that's the reason why you're standing here, rightly so. And I was also impressed by your work. I think you did it in a very challenging context. not to mention even the COVID, but also in general, I think. And as if one country was not enough, you did it in 3 countries. So, well, respect. And you also paid attention to implementation as well as return on investment. So a lot of compliments. And I also know you as a very good teacher, by the way. So all positive here. And because of that, before I go to my question, I decided to give you a little break and asked first one of your paranymphs to read a question, proposition 2.
The development of community support for improved alcohol measurement and brief advice needs to be tailored to the cultural and contextual characteristics of the respective community in cooperation with local stakeholders.
Thank you very much. And my question, I want to zoom in on the aspect of this proposition tailored to cultural and contextual characteristics. I think it's hard to disagree with that statement. But of course, it raised immediately my question, because when you receive this book, this is always the first thing you read. And it raised my question, okay, how did she do that? So I started reading, and then I saw in chapter 2 that you mentioned these adoption mechanisms. So my first question is this what you mean with the tailoring to cultural and contextual characteristics?
Highly esteemed opponent, thank you very much for your compliments and the question. So, how did we go with about tailoring in Scala? This was actually quite an important stage of a part of the whole Scala project. We had about a year to tailor these materials and the whole approach of the clinical intervention in the 3 countries. And we mostly did it through with the help of the Community Advisory Board, who gave advice on how feasible is, for example, the intervention in the 3 countries, but also more specific advice on the materials that were used, for example. So the leaflets that were given to the patients, what kind of information should be included there. And so that was one way of doing this tailoring. We also had user panels with both patients and healthcare providers, who also gave advice on particularly on the fact that the intervention as it was initially proposed was quite long. So they said we actually wanted to be more simple, and that's what we took also into account. So, and the adoption mechanisms were I wouldn't say that they were necessarily planned in order to tailor this intervention, but they were developed in accordance to the context of each country. So, for example, more in the sense of the format, how this was given, in all countries, they found it important to use adoption mechanisms such as meeting with healthcare providers to explain the benefits of the intervention. But this was done more often, for example, in Colombia than in Mexico. So. They took this kind of differences into account.
Okay, so looking at these 5 pillars that you just presented, it was less the focus on the adoption mechanisms, but more so on this community advisory board and this user interaction. So it's almost kind of like a co-design.
Yeah, it was indeed more of a co-creation approach of this community support and also of the whole intervention. I would say also the communication campaigns were also a part of the community support that allowed for more tailoring, because as we also saw with the posters, they were quite different. So that was interesting to see actually the countries we developed quite a common approach because we did it together with the 3 countries, but we still saw differences in
and if you say because this is more the cultural aspect, and you mentioned already differences between countries. But you also talk about communities all the time, and then I think at a even lower level. Is that the case, or is it tailored at the country level?
No, we did it indeed more so in Scala we use this municipality as a scalable unit basically. So we had in each country indeed 2 municipalities that we compared. So we assumed that the approach would be in the end feasible for the whole country, but how we did it in Scala was on the municipal level. So we saw, maybe then to give an example of for example, the communication campaign was done in Colombia, not only in the primary healthcare centers, but they also, for example, placed posters also in local markets or in pharmacies, because they found that also to be a suitable place to reach the target group.
Yeah, but were there then also differences between those communities within Colombia or within Mexico?
So the two communities within each country. Yeah, I think there were some differences, but we paid attention during the project that these were really comparable municipalities. So they were also geographically quite close to each other. So I wouldn't say that these differences were very large.
Okay, yeah, because that leads to my final question then, because indeed I saw in chapter 3, then you kind of divided the analysis per country.
Yeah.
But that's about it. So, but you also present like overall analysis. Is this like, would you say that it's feasible given this tailoring? Or would you say like, it's still too general that I can lump all these data together?
Yeah. So in the end, what we saw that were so the differences in these activities were more in the format of how it was implemented, but the general approach was quite similar. Ideally, we would have done. So, for example, with the mechanisms that we tested later on in chapter 3, we would have wanted to do it also statistically, to test the statistical differences between the countries, but we unfortunately could not do it because of the limited sample size. But we did see in exploratory analysis that the effect was nevertheless in the same direction in all 3 countries. So, I think also because we really also focused on the perceptions of the healthcare providers, of how they received this community support, that this in a way also allowed us to look at the whole sample.
Okay, thank you very much. That's reassuring. I give the word back to the chairman.
Thank you, Professor Crutzen. The opposition will be continued by Dr. Smit, Associate Professor of Health Communication, University of Amsterdam.
Thank you very much. Dear PhD candidate, first of all, I'd like to congratulate you and your team, of course, on your interesting thesis. It's been a pleasure reading it, and it reflects, as Professor Crutzen also already emphasized, what I think must have been an extremely challenging project. Having once been your research master thesis supervisor and now being one of your direct colleagues in Amsterdam, I feel especially honored that I can now also exchange some ideas with you about your dissertation. Because I do have some questions, of course. First of all, in your general discussion, you described that it's important to move beyond tailoring based on community characteristics to also take into account individual characteristics when planning and executing community support. And you suggest that targeting or tailoring of the content or mode of delivery of these community support interventions might increase their effectiveness. And well, you know, this is an area that interests me. So I would be keen to hear more about what exactly you envision here. And I wonder, to what extent could targeting or tailoring be helpful to achieve, for instance, the 30% alcohol measurement rate that you described in the hypothetical, most optimistic scenario that you tested in chapter 5. And I have a follow-up question as well, but maybe you can elaborate on that first.
Yeah. Esteemed opponent, thank you very much for your compliments and the question. Tailoring and also for e-health could be a way of how primary healthcare providers could be more motivated to deliver this intervention. So I think there are many areas that could work here. And now, if I would think of what could be interesting to test is. First of all, what we saw indeed in Scala is that when we looked at the effect per healthcare center, then the effect of community support was not so visible. But when we looked at the individual, at the individual level, we saw this effect indeed appeared. So yeah, this is a reason why we think that targeting the individuals could also be very promising. And when we would use tailoring for this, we could, for example, assess what is the what are the current attitudes of healthcare providers or beliefs and their motivation to deliver the intervention, and then based on that existing attitudes, we could then tailor the intervention to them, for example, through digital techniques. For example, with maybe we could incorporate some online training modules that could then really build on the knowledge, but also attitudes that they currently have. So yeah, that could be a way of making sure that this is maybe more efficiently done. And thinking of how this could be used to achieve this 30% rate. So we actually saw that in some studies done in Europe, we saw that, for example, in Sweden, this rate of patients that are discussing alcohol with their healthcare providers is approaching 30. It's about 25, if I'm not mistaken, or 27. So we saw that, okay, this is possible in some countries. And what we think that could work is, what we also then describe in chapter 5, is that you would first need a push more from the opinion makers and from the authorities to really recommend this intervention, and then once this awareness is more created, I think then we could then implement this more individual oriented tailoring techniques.
Yeah, okay, thank you. I actually had another follow-up question, but now you triggered me. I wonder, because also when reading more about the return on investment study, you suggest that to upskill the program to further improve this return on investment, less costly implementation strategies may need to be considered, such as media campaigns to raise awareness, for instance. But I know also that you have some experience in evaluating public information campaigns. And when I looked up the article about your work, I actually found out that you concluded that few direct effects were actually found of media exposure on persuasive outcomes like awareness. So I therefore wonder to what extent, and maybe more importantly, how then, you think this 30% of alcohol measurement can in fact be achieved when you add media campaigns to the Scala mix of interventions?
Yeah, I think it's indeed, we shouldn't be overly optimistic about the media campaigns. What we do see is often that even though maybe we don't find direct effects of media campaigns, we do see that it has an effect through interpersonal communication. So that maybe through this interpersonal communication, so people starting to discuss more about, for example, the benefits of the intervention, then such effects can be achieved. So we kind of need to create, basically first to raise more awareness, to make it a subject, a visible subject, and then even though maybe the direct effects are not that visible, I think in time we could still see some positive effects. Maybe indirectly.
Great, very interesting. I'll give the word back to the prorector.
Thank you, Dr. Smith. The opposition will be continued by Professor Mures, Professor of Primary Care, Maastricht University.
Thank you very much, Mr. Prorector. Dear candidate, congratulations with your great work, and I understood that you coming from East Europe, fluently speaking Spanish and doing, of course, the research in a very different continent. That's a very good thing to do, and I still see that you're still vivid and alive and going on with your career. So that's a great effort. You already did a great effort. So being a GP, I'm very sorry that I have to go back to the consultation room and where the doctor and the possible drinker are confronted with each other. And you were talking about context and context of influencing the doctor. But what I see in practice is that it's my very brief advice, or even assessing, you call it measurement, assessing whether someone drinks heavily or not, or binge drinks, is done in the context of the doctor-patient interaction. What I see is that well, some campaigns, like from the government or public health officers, there are one intervention and I have to do it in my practice for every patient. But I see I have 3,000 patients, and everyone is very different from each other. So we in general practice are more, in Western Europe, are more on person-centered care. So how can you do an intervention that is developed by boards, CAB, I don't know what it is, community advisory boards, I think, where only public health workers are involved, but no GPs. I now learned that in user panels, the GPs are in. So my question is, was the person-centered care taken into your intervention? I see a lot of difference between female and male patients in responding to my questions, and also the elderly population has a very other connotation with alcohol. So could you elaborate a little bit on that?
Highly esteemed opponent, thank you very much for your compliments and the question. So yeah, we also thought indeed that it's crucial that the perspective of the healthcare provider, so mostly the GPs, but also the nurses, for example, is also taken into account in the Scala and project, and that's why we also had the user panels with both patients and separately with healthcare providers to really make sure that, so that was at the beginning stage of the project, to make sure that this intervention is feasible for implementation. And so that was, yeah, the exercise that we did to take the provider perspective into account. And what we did, for example, with it was that we, in the end, shortened the intervention quite a lot. And we, for example, also offered the option to, or we changed it in such a way that the provider would first only ask just a short, the Audit C questionnaire with only 3 questions, assessing alcohol consumption, and only when that was considered risky, then the provider would go on to ask more questions. So this was...
So
yeah?
sorry to interrupt you. In my practice, there are, well, it's not a very gender-sensitive remark, I now realize, but there are women that will not talk about their alcohol consumption to me because they drink at home where nobody sees them. They are a little bit depressed or something else. How can you bring up this information by a very brief instrument, very generally designed? So back to the person-centered care again.
Yeah, but back to the person indeed. So we think that just by touching upon this topic, and also, for example, with the communication campaigns, which already raises more awareness on the subject, that maybe even I can imagine that even if it doesn't work the first time, it will become less of a taboo topic when you see that it is discussed more often. But it is a topic that is more common also for other patients.
And how did you train the primary care team to deal with these contextual factors?
So yeah, we had indeed a training in Scala, which was also tailored to the needs of the countries, and we also, in our approach, in the end, we also encourage the primary healthcare providers to also make their own judgment. So, for example, when a patient really needs more detailed information or more in-depth help. So. What we also saw is that some healthcare providers delivered it more often to their patients, and some others were more selective about who is receiving alcohol measurement and who not. And that is probably also then reflecting a bit of the patient perspective. So when you see that you have maybe not so much time in a consultation, then you can still make the decision, okay, I'm not going to address this topic now.
So many elderly patients are used to drinking alcohol. It's a part of their culture. They socialize with alcohol. How did you teach the primary care team to break up these mechanisms?
Yeah, I think in Scala, or in the training that was offered in Scala, there were not really very specific examples given on, okay, how you do you deal, for example, with older population, or maybe some specific examples. Although
I saw some videos on the Scala website.
Yeah, and but I think that would be an important aspect to take into account for the future.
So. When I compare general practice to the Netherlands, and you said already they were trained in motivational interviewing, the primary care team, I think that my hypothesis is that many doctors in Latin America are maternalistic, or to say it in another gender way, paternalistic way. How did you combine motivational interviewing, shared decision making, with a kind of authoritative way of doing your practice? Do you understand my question?
Yeah, okay. I understand. So in the end it was each provider decided, or we offered an intervention, and then everyone, of course, included it in their own practice. And I would say that this more paternalistic approach that you mentioned in the end can also actually lead to more effectiveness of such intervention, although that's not what we measured in Scala. We did not test the effectiveness on the alcohol consumption, but I wouldn't say that that is necessarily a disadvantage. Because
but you didn't measure authoritarian way of practicing, huh? You didn't have a scale for that?
Not in the studies that were the subject of this dissertation, okay. No.
Would there be time, dear Pro-Rector, for one short question? Is that allowed from your side? Thank you very much. So my last question would be how, if you would adapt, according to my suggestions, this intervention, how would you bring Latin America to a learning in a learning state and an implementation state of your measurements? What would be your methodology now, from now on?
So basically, how to scale up our project and implement it.
To scale up, but also to have a more learning attitude and understanding attitude of the primary care team and to implement the intervention. With the aim to scale up, of course.
So then, if I understand it correctly, the question then basically how to make sure that we take these attitudes, for example, into account, or ways of.
So what methodology should your successor PhD student take? Would it be a randomized controlled trial or a case control study or whatever?
I think what would be important is to have maybe a more formal needs assessment of what is really needed to implement in the project. So really to tailor it in a way to the existing practice. And I think depending on the intervention that you develop, a randomized control trial could be a way of going about it.
Thank you very much. I'm not fully satisfied with your answers, but we'll come back to that during the reception, I think.
Okay, thank you.
Thank you, Professor Mures. The opposition will be continued by Dr. Unema, Associate Professor of Health Communication, Open University, Heerlen. Dr. Unema.
Thank you. Dear candidate, I also want to start with complimenting and congratulating you with your very nice dissertation, and of course also compliments for your team of supervisors. I have read your dissertation with great interest, and what I really liked about it, that you managed to describe the results of a very complex project in different countries, far away, in a very complex situation due to COVID. But you managed to describe that in a very clear and accessible way. And I think your dissertation also shows that you master a lot of different research methodologies and also different analysis techniques, including intervention development, community support intervention development, and also cost analysis. Cost analysis. So compliments for that as well. My questions relate to the first part of your dissertation, so the intervention development, and more specifically related to chapter 3. In this chapter, you show that community support has a small effect on alcohol measurement and brief advice, but yeah, it's only small, which is of course good and also promising, but I think there's also a lot of room for improvement of these community support components. You put a lot of effort in it, and also based on the theoretical framework that you used, really this community support intervention should have made the difference. Is that, yeah, I see you nodding, so you agree with that. So in chapter 3, you also try to analyze some of the potential mechanisms that may bring up, that you expected to bring about effects of the community support interventions on intention and behavior. But a lot of these associations that you expected, you didn't find it in the results. So my question is, when you focus on, reflect on these findings, can you find some ideas, some suggestions of how to improve your community support components?
Esteemed opponent, thank you very much for the compliments and the question. Yes, indeed, it is true that the effect that we found of community support was rather small. So we had 6% of the patients receiving alcohol measurement in those arms of the study. But what we also mentioned in the discussion is that given the limited time that we had to implement this community support, it is quite a promising result. And I think always there is way of how to improve it. So what I would do in a future study, I would really allocate more time and resources to have a more formal assessment of what is needed in the 3 countries in terms of, for example, communication campaigns, what kind of beliefs should be tackled, So that is something that we couldn't do as formally in Scala. So I think that would be a way of improving it. But also what would be really important is also to really allow for more time for this community support to have its effects. Because initially we planned it for 18 months, so yeah, we had to stop it, but for example, the communication campaign, which was one of the main activities in the community support, was not really implemented. So I think when we would have that, then the effects would be probably also larger.
Okay, thank you. Yeah, I read in your dissertation that your explanation of not finding these mechanisms was, yeah, well, it was not implemented yet as it should be. But still, then I thought it was a little bit like expecting that the effects will come about later. So that is possible, of course, that will happen. But yeah, I thought it could also the findings of specifically of your mechanism study gives ground for further elaboration and also further thinking about what's going on here. Because yeah, either the community support intervention did not do what you expected it to do, or you did not look at the mechanisms that result in the change. So what of these 2 things do you think is most likely?
So you mean really looking at the separate mechanisms that were implemented in the...
Yeah, so did you look at the appropriate mechanisms, or are there maybe other mechanisms that you should look at? Or is it that your intervention should have other components to drive these mechanisms?
So the conceptual model, then, really the mechanisms. Yeah. Yeah, I think you can. There are a lot of other possible mechanisms that you can take into account. So maybe when you would, for example, also assess, for example, the motivation of providers to deliver the intervention. You see also different types of motivations that could have also maybe played a role in in explaining the effects or lack thereof. But that, we didn't include that in our conceptual model. So that could be something that can be done in the future. And And if with the sample size would allow, then it would be also interesting to look also at the different activities that were implemented in the community support to see whether the effects also differs. Because what we saw also more from qualitative interviews that we had was that, for example, the one particular support system, the giving feedback, regular feedback to providers was really quite an important part. But we, in our design, we took the community support as a whole. So for future, it would be also interesting maybe to look at these separate effects, and then that could inform future development of community support.
I think that would really support in finding out what works and what doesn't work and what can be improved. Can I have a brief last question relating to the implementation of these community support components? In your model, awareness is a mediator of the effect on self-efficacy. But that also means that the intervention components have to be implemented as intended. And of course, you mentioned already it was not possible to do it fully because of the limited time. But given the time that was available, I think it was 5 months, do you have any information about the level of implementation of the components that had to be implemented during that time?
So the level of implementation was so according to the schedule of the community support. By that time, we had the adoption mechanisms and support systems implemented. So if I would make a brief comparison between the countries, I would say that. For example, in Colombia, the support was maybe even a little bit higher than in Peru, for example. But overall, we did see that they were, those support activities were implemented as planned. So particularly the adoption mechanisms and support systems.
Okay. Yeah. Thank you. I give the word back.
Thank you, Dr. Unma. The opposition will be continued by Dr. Hilligsman, Associate Professor in Health Economics and Health Technology Assessment, Maastricht University. Dr. Hilligsman.
Thank you. Dear candidate, first of all, I would like to congratulate you and your promoter team for the great and interesting thesis. Being myself a health economist, I was happy to see some cost and economic component in your dissertation. And you could also expect that my questions would be related to this cost part, and especially the chapter 5. And my first question is about the methodological choice, about the method you selected, the use of return on investment. In your introduction talk, you also mentioned that the challenge is to translate the health outcome in monetary terms. As health economists, we also often use another method called cost effectiveness, where we compare intervention in cost and in QALY for quality adjusted life years. And you also mentioned QALY at 2 places in your dissertation. And I would like you try maybe to convince me that a return on investment is the best approach in this project.
Esteemed opponent, thank you for your compliments and your question. Indeed, we have in health economics, health technology assessments, we have different types of economic evaluations. And we also considered in the beginning doing a cost effectiveness or cost utility analysis. We had 2 reasons for going with the final approach of a return on investment. We were really interested in seeing indeed what would be the monetary outcomes, because we saw that in the countries, especially in the more countries that are not high income, this kind of analyses are really useful also for policymakers. So that was one reason. The second reason is that for cost utility or cost effectiveness analysis, you need to also focus. You need data from the patients, and you would need to measure it at least 2 times, so to really see an effectiveness of the intervention on their alcohol consumption. So you need the trial-based information, and that is unfortunately something that we could not do in Scala. So that was in the end also a limit of our research.
Yeah. And regarding quality of life, do you think that some measurement on the quality of life would have been important? Because you also mentioned that you avert some deaths with the intervention, but could we also expect to gain maybe some quality of life? And that quality of life could also be converted in some maybe additional monetary gains?
Yeah, I think quality of life, that's also what we often see in cost utility analysis as an outcome. And I would say it's a very relevant outcome to look at. Also in the context of alcohol consumption. So I would say that this, for sure, also for future research, that would be a good avenue to take. Again, then it should be feasible in the research that you can also have this longitudinal assessment also of patients, and then that would allow to see differences in quality of life.
Thank you. And maybe looking at the other dimension, the cost. You also mentioned that the costs were quite limited. I know it is a challenge to assess a lot of costs, but only the hospital nights and the admission to emergency department were included. And then you did an extrapolation for the other healthcare costs. But if you had the opportunity to collect every type of cost, which type of cost would you recommend to assess, and how would you measure the cost?
So yeah, depending on the perspective, I would say that for a real outcome of this return on investment or for an economic analysis of an alcohol measurement intervention, you should actually look at societal costs and the returns. So that would go beyond the healthcare system and really see what it does, for example, in terms of productivity loss or criminal justice costs. So that would be the more ideal approach of going about it. But if we would look at only at the healthcare perspective, I think that you could go, how we did it in Scala was really looking at real data from the Ministry of Health. And I think the best way is when data is really open in most countries. So we see that in Europe that's more, or in high developed countries, high income countries, this is more often the case than in middle income countries. So that would be the best approach from a research perspective to really have this data and then use it. And otherwise you would you could also do it trial based, so really ask patients how often have you been hospitalized, and then for which disease, or how often have you been in emergency care. Yeah.
And you also mentioned the societal cost that also include non-healthcare cost. Do you think that, for example, vandalism is something that we should also include in this return on investment?
Yeah, from a criminal justice perspective, yeah. And even material costs, but maybe that's a bit could be a bit challenging to model. But yeah, for sure that is also something that we see from alcohol.
Yeah. Okay, thank you. And a last question regarding the time horizon of the model, because you use 10 years. I know we need to make some choice, but every choice is arbitrary. Why 10? Maybe not 11, 9 years, 15, or 5, or maybe even over the lifetime. First question, do you have a rationale for selecting 10 years? Do you think it's really maybe a best time frame to collect the return on investment? And another related question, do you think if you extended the time horizon of the model, do you think that the return on investment could be even higher?
Yeah, so for the first part, indeed, choosing the 10 years was, we saw that 10 years is also what it makes sense also for policymakers. They can really, it's more of a segment of time that is understandable for policymakers. But I would say the main reason was also that we had, that was also the data that we had from the Ministry of Health. I'm not sure if it was exactly 10 years, maybe it was 11 or 12 years, but that's when we had the open data that allowed us to include it in the model. So it was a combination of these two strategies or two reasons. And I think if we would look at longer term effects, I would say that then they would be longer or higher. The effects would be higher. I would expect reducing of alcohol consumption to have also longer effects in time, because then a person becomes healthier and the healthcare they need is also reduced.
Yes, agree. I would have been pleased to ask you additional question, but because of time, I will give the word back to the prorector.
Thank you, Dr. Helligsman. The opposition will be continued by Professor Bos, Professor of Clinical Psychology, Open University Heerlen. Professor Bos.
Dear candidate, first of all, I want to congratulate you with this thesis. I've read it with much interest, and it's really nice that you examined to what extent community support could increase the delivery of alcohol measurement and brief advice in primary healthcare settings. I was a little bit shocked by the low percentage of patients that got the alcohol consumption measured. Only 3% in the control group and only 6% in the community support group. That's what Dr. Undema also mentioned. It's still a low percentage. It is clear that even in the community support group, 94% of patients did not receive alcohol measurement, so there's still room for improvement. So my first question will be about why it's so difficult to do that alcohol measurement. And one reason could be that the healthcare professionals still feel not skilled enough to take these measurements and talk about it with the client. And I visited the Scala website and I found information about the training. And it looks great, but it's only 2 hours. And you get a lot of skills you need to learn, like motivational interviewing and things like that. And I wondered, is those 2 hours too short? And is there still room for improvement in the training program? That's my first question.
Highly esteemed opponent, thank you for your compliments and for the question. When we look at the absolute numbers of patients, we see indeed that it's quite a small effect, although it started from even lower, so there is some improvement already there. And the training, I think, when you give more training, that the effects on the self-efficacy would be, we would expect it to be higher, but we also need to take into account the feasibility of providing such training, because it was already quite a challenge in Scala to even find the time to give the training, because this lack of time is also always felt as an obstacle for healthcare providers to deliver the intervention. So theoretically, it would be better to give more training. I would say that also when we include the community support component, then what we also saw after a while in Scala is that when providers become more aware and motivated to discuss about the topic, they even train each other through informal training, for example. So maybe we should not stick to only these formal trainings, but also see, okay, how can we make this intervention more sustainable so that it becomes more of a living subject. And that would eventually, hopefully, also lead to more patients receiving this intervention.
Okay, that's nice to hear that they start to practice with each other, so then they have more practice. I had another question about the attitudes. You also train, or you discuss attitudes with each other very shortly in the training. And I think alcohol misabuse is a highly stigmatized condition, and I wondered if those negative attitudes that healthcare professionals might have and the embarrassment that patients might feel to discuss about it might play a role also in the fact that not so many people had the alcohol measurement. And is there something you can improve in the training to address that? Because now you really shortly discuss with each other, and maybe you need a more intensified stigma reduction training.
Indeed, we saw also from literature that alcohol is quite a stigmatized topic, and I would say maybe even more in maybe not in the whole Latin America, but we saw even differences. For example, in Peru, we see that this was less of a approachable topic than, for example, in Mexico. So even at country level, there might be some differences. this indeed shows that stigma has to be addressed. This is something that we also tried to do also with community support. So we wanted to make the topic more salient in the patients and in healthcare providers. So, for example, when you can refer already to a poster that is in the primary healthcare waiting room, maybe it's a bit less of a barrier to start addressing the topic in a healthcare consultation. And the training, ideally, it should also then focus on the needs of each country. And I think it was also, we had in the trainings also a time when the providers could also ask the questions, so they could tailor it a bit already to their needs. And when such questions would come up, then you need to make sure that you know how to answer them.
Okay, thank you. I have another question. It's more about clinical psychology. You want to prevent people or you want to help them to refer them to treatment if they drink too much. And how many people were referred? And how is the treatment of addiction organized in Latin America? Is it possible, if you are very successful, to refer all those people to treatment programs, or is that not so easy?
We saw quite small numbers of referral. I think less than. For sure less than 1%, but even less. And that was also something that we, so basically the referral was, had to be judged as appropriate by the healthcare provider, so that would really be more in terms of addiction, when addiction is more found or judged. And then in the countries, you have, for example, rehab facilities or more, you can refer them to clinical psychologists, if that is needed. But if you would compare it to, for example, Western Europe or other high-income countries, then it's less. Mm-hmm. So that was not, also did not happen that much in Scala.
Okay, and I have a final question. In the program, it's also that this project is about morbid depression. But I wondered, was that also measured by healthcare professionals? And what is the place of comorbid depression in the project? And what have you done with it? So comorbid depression was included in the instrument that the providers use. So because we see that comorbid depression is indeed comorbid with the alcohol consumption. So they had two small items that they also asked patients. And then when the score was quite high, then they could receive more questions to assess, for example, even a suicide attempt. What we saw in the beginning of the Scala project was that also the data that we included in this dissertation was that was not so popular with healthcare providers, so they didn't do it that much. And we did see a large increase during the COVID-19 pandemic, because that's when a lot of patients, mental health became a very important subject. So we actually also, we saw that everyone was really asking about depression.
Adriana Solovei, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Adriana Solovei. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Dr. de Vries is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. Professor de Vries.
First question. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Adriana Solovei, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with a degree certificate signed by the rector, the secretary and the other members of the committee, and affixed with the official seal of the university. Well, dear Adriana, congratulations again. Early in 2018, you got appointed as a PhD researcher on the Scala project. And that was because you had done 2 interviews, also with assignments, and you really gave a good impression during these 2 interviews. So we decided to appoint you. And I think we made a good choice. And actually, you were very eager to participate because you already participated in a Skype meeting of February 28, and that was earlier, I think, than your official starting day, which was March 1, I think. So that already shows that you were very motivated to do this job. And at the beginning of the project, it was not exactly clear what the tasks were going to be. And of course, the work packages of the project were clearly defined, but that doesn't mean that all the details for a research project are spelled out. And they had good and less good sides. The good side was that there were a lot of opportunities for you to realize, to take on board. But the negative side was also that plans that you had made also could be changed and had to be changed. And also when the plans were made, then you had to change them again because, you know, the project was changing, or as you already outlined, some costs could not be calculated because we could only see the patients once and not twice as we had hoped. So it was a constant test of your flexibility and resilience in that sense. And I think also there we can say that you passed that test very well. And I'm impressed by you, certainly in the beginning, because you were young, a student, and then in the middle of a context, such an international scene, and all your projects, your ideas, well, wonderful ideas, but only so few of them could be realized. But still, you did a quite job with those that you did realize. So congratulations for your resilience and flexibility. And also, for instance, what I thought would be the most clear part, the cost-effectiveness analysis, we already alluded to that, was not as clear as thought. So you also had to change there. And together with your team, and in particular with Jürgen and Jakob, and in the beginning also with Sylvia Evers, you managed to analyze the cost in a different way. And Michael, of course, may have other ideas, but this was the only thing I think was, at this moment, was possible in that challenging situation called Scala. So not everyone could have what they wanted, of course. But that's a part of a big project where you have to also adapt to the context. And second, the idea of analyzing the community actions was, amongst others, introduced by Eva Lopez on her already slide of 22 in 2018. But how to do such a thing, that appeared a quite interesting journey, because again, the details were not spelled out. But if I look back at your results, I'm very positive and impressed on how you and also your team approached this effort, because there's not that much done out there on how to measure community activities, and certainly not in this context. So you came up with several interesting ideas, and actually some of them they are not yet realized. I remember some of our discussions on doing some experimental studies, for instance. I think they're still worthwhile doing, so maybe in Amsterdam you can still do it. And apart from your PhD task, you had also other tasks. Rick already mentioned the teaching, but there were also within Scala were tasks that you were doing together with Dutch, who's now parent, and will defend on May 2. And that also, they were not easy tasks. They involved a lot of time and nitty-gritty work. I'm glad that you did it, and I didn't have to do that, because, my God, they were really sometimes awful. But they were needed for the EU reporting. So compliments to both of you, actually, on how you managed to combine these tasks with your PhD tasks. And then we had COVID. The whole world froze, and so did the Scala project. The whole planning got disturbed, and we could not do the things as we had planned in Mexico, Colombia, Peru. So this was really a pity, not only for you doing the research, for all the countries, and certainly, of course, for Eva and Peter, the PRs of the Scala project. Yet, you did a wonderful job in adapting, the whole team. And although face-to-face meetings were not possible, also at Maastricht level, we still had, very good and productive meetings, then via Zoom. So you developed, despite that, also a new highlight. You became mother, and I think there is your, well, it's not a scientific paper, but it certainly is worthwhile in life to produce as a scientific paper with a high Hirsch index. So congratulations to you again on how you can combine the role of a mother, with being a researcher. It's always challenging, and I think you did very well. So, Dr. Adriana, during the Scala time, doctor, how does it sound? During your Scala time, I really liked working with you. You were always very motivated, eager to continue to develop and realize your plans, but also, learning that you had to adapt your plans to, what is possible. And I think you actually really managed to find a good balance between your ambitions and finding out what was possible within the larger scheme of things. You have very good analytic and writing skills. You're a nice person to collaborate with, and you also can defend your thesis very well, which has been the conclusion of the committee here. So you're now working as a postdoc at the University of Amsterdam, and I think that will be an excellent opportunity for you to develop your academic career, in much more. And I really want to congratulate you with your achievement today. I want to include your family and friends with this great achievement that you realize today. Well done, and I will now pass the word to your other supervisor, Lisbeth.
Thank you, Hein. Dear Adriana, dear Dr. Solovei, from the very first moment you worked hard, professional and passionate. You were eager to learn and immediately dived into the Scala project, a project that asked a lot from you as a fresh PhD student. Within weeks, you were in the middle of meetings with researchers from Peru, Colombia, Mexico, Germany, UK, trying to find your way in the complexity of the many work packages, project deliveries, and deadlines. And when I, above all that, proposed you to stick to Dutch instead of English in all our one-on-one mails and conversations, you accepted that extra challenge eagerly, resulting in you confidently teaching in Dutch now. Step by step, you grew into the project, and no matter how busy it was at times, no matter how Scala suffered from COVID, you never gave up, and I have a lot of respect for your perseverance. Your PhD trajectory was not at all a standard one, and you may not have gotten the chance to do all the things you dreamed of doing, but it was a unique and valuable experience that made you the researcher that you are now. It may even have learned you a bit about yourself as a person too. Talking about you as a person and not a researcher, you were and still are very loved among colleagues. No matter how busy you were always very caring and interested in how others were doing. You always made time to listen. You even hosted a surprise party for a colleague last minute at your place at home when the original host, sitting behind you on the right, fell ill. In your personal life, it did seem that your dreams were coming true. You married Niels and welcomed little Simon into your family. So now you are Mrs., you are mom, and you are doctor. I will not ask you which one of the titles was the hardest to obtain. Dear Adriana, now my role as your supervisor has officially ended. It is time for me to thank you. It was a privilege to supervise you. You are more than ready now to pave your own way in the academic world, and wherever it may lead you, I sincerely hope that we can work together sometime in the future and have our cozy coffee meetings again. Congratulations with this great accomplishment and your new title, well done. Furthermore, I would like to congratulate Niels, little Simon, your parents, and other family members who are here, also on behalf of Hein again, and Eva, who was also a team member. And we all wish you a very beautiful day. Thank you.
Dear Dr. Solovei, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. You did a great job. I would like to thank the members of the evaluation committee and the Corona to contribute so effectively to this ceremony. Thank you very much, particularly for our colleagues also from the University of Amsterdam and from Hele University. I hereby close this academic session. We will first leave the Corona, and the candidate will first leave the room to make a picture on the stairs of our building, and then after that